So as you can read, I'm going to speak about the impact of cerebral autoregulation to the outcomes of severe head injured patients. So, sitting here from the morning, I realized that not all of you are neurosurgeons working in the ICU with severe head injured patients. So I divided my lecture to a few parts. The first part is just some things about the intracranial hydrodynamics. And then I will switch to the studies that our group had done and published. So we're speaking about the brain. And brain is a strange small organ. It's just 2% of the body weight. But this is metabolically inactive organ because it's taking about 15% of the blood in every cardiac cycle and accounts for about 20% of the total oxygen consumption. And we know that without blood supply, irreversible changes are observed within 5 to 20 minutes. And when this blood gets into the brain, it is used extensively. About 50% of oxygen and 10% of glucose are taken away from the blood flow. And what's interesting more, that there are no reserves in the cranium, in the brain, to have this oxygen and glucose. So what we need adequate and continuous nutritional blood flow. So, blood flow, what it is, we know the values. It's about 55 to 60 milliliters per 100 gram of brain per minute. And it is different in white matter and gray matter. Why? Because in gray matter it's higher because the bodies of neurons are here, and in white matter it's less of them. And actually that's the place where the metastasis grown up when they spread through the bloodstream, because there is a change in diameter of the vessel between the gray matter and white matter. Okay, what happens when we have decreased cerebral blood flow? We have this stroke, infraction. When it is increased, we have the brain swelling or hyperemia, which usually leads to the brain infection afterwards. And can we see the blood flow? That's no problem. There are a lot of nice methods to do this. CD perfusion, what is used by the neurologist in everyday practice. Yes, we can do the MRI perfusion, and you can see the hyperperfusion on the left temporal occipital lobe. And the best thing is positron emission tomography. It's the last picture, and you can see the hypoperfusion on the right occipital lobe. But the problem here, it's just a screenshot. We cannot use these modalities for monitoring. We just measure the perfusion at the moment we measure. And it's not can be done continuously. Well, maybe there are some other modalities to do this. Yes, it's ultrasound, for example, transcranial Doppler. We can measure the one vessel, that is just one vessel. You can implant the transducer to the brain, but it will show you just a regional blood flow, not the blood flow of the whole brain. So in general, it's a pity that we don't have a method for monitoring. We have to measure it, but we don't have a method for monitoring. Now, what else we need for the CBF? Of course, systemic circulation. I'm not going deep into this, but the blood is coming from the heart to the brain and coming through the four main vessels, four main arteries. That's two carotid arteries and two vertebral arteries. And what is here interesting, that we're speaking about the arteries as well, and there is in our mind, there is no difference between the child and the adult, and the grown and adult and older person. And there are a lot of changes because, for example, carotids, they are not elastic anymore with age. We can have stenosis, atherosclerotic changes, and we are losing the elasticity of the vessel and the ability to react to the changing requirements of blood flow. When we get into the brain, we have the intracranial arteries, circle of Willis, and Dr. Bauer mentioned it today, that, well, the normal circle of Willis, as it is in the textbooks, is about in a half of the population only. So we have a lot of anatomical variants and a lot of physiological variants of the blood flow inside the brain. And for example, we can get the blood supply from the left vertebral artery to the right anterior cerebral artery, and that's normal. But we have to respect this. Then we're coming to the capillaries. What's interesting with the capillaries in the brain, they are perfused in about 80%. 80% of them are perfused all the time at the rest. That's a major difference from other organs. For example, in the muscles, it can increase tenfold when we're active, and they are decreased when we're at rest. And in brain is active all the time, and we have only from 10 to 20% reserve to change the blood flow when we need some, when the metabolism is changing. Now, the brain itself, well, that's two pictures. The first one of a newborn, and the second is of a person aged 75. You can see that the first picture, well, it's this head is full of brain. Yes, for the older one, yes, there is brain, but we have a big space of CSF, and the brain elasticity is completely different. And again, we're speaking about the different persons, a newborn and an old one, in a range of intracranial hydrodynamics. Then the blood is filtering through the brain and getting into the veins. The veins are normal as everywhere, except for the venous sinuses. That's the only place in the body that the vein has the rigid walls. Why? We do need this. Well, actually, it's when they're standing up, the intracranial pressure can be negative. And if it is negative, this vein can collapse. And we need an open vein all the time, open sinuses all the time. So that's why our venous sinuses are never closed. There's always a place for blood to run out of the brain. And then we have CSF. And CSF is, well, it's a major buffering system. I will speak about this in a few moments. And to make everything more complicated, we put all this stuff, all the brain, the blood and CSF into the cranium. And cranium is a rigid box, and it cannot expand. And what is interesting that everything intracranial cannot be compressed. Brain is a water with something, blood, a water with less something, and CSF is just the water. You can't compress the water. And that means that every volume that is put into the cranium, the same volume should pass out. And that's the doctrine that's coming from the 18th, 19th century, Swan-Kelly doctrine, that if we put something into the cranium, the same volume is getting out, and what we put in is blood. On every systole, some volume of blood is entering the cranium, so that means that this same volume should pass out, and that means that brain is not pulsating. That's not true. Even the Hippocrates in his book, he wrote about the head injury, and he said when you find a patient without a cranium, put your hand on the brain, and if you feel it's pulsating, do something. If it's not, this patient is gone. So we know, that the brain is pulsating, and that's the correction which comes in 1848 by Burroughs, that we have a special system, that's a CSF system, that redistributes inside the cranium between the supratentorial and infratentorial compartments and between the intracranial and spinal compartments. And this is the buffering system which lets the blood to enter, CSF is flowing out, and then taking the place when the blood enters the venous sinuses. So there is some possibilities to accept some additional volume, and this is a relationship between the volume and pressure. It is called cerebral compliance. What we see here, a clear blood is coming in, it's changing for the venous blood that is getting out, and then we have the CSF that is compensating this volume. Do we see this in our everyday monitoring? Yes, we do, and this is a pulse wave. These are pulse waves that we can see, we can follow on the monitor. But what's interesting here is amplitude, because the same volume, the same volume for here, if we have the relationship, and this relationship is not linear, it was set up on the end of last century by Professor Marmaro, the same volume of the CSF provokes a different reaction of impression. The amplitude can be big, that means that cerebral compliance is low, and the amplitude of the pulse wave can be low, that means that cerebral compliance is high. Can we monitor cerebral compliance with the pulse waves? No. Why? Because it's very individual. It depends about the viscosity of the blood, about if this patient is standing, laying down, or there is some procedure, so we can't take an individual normal value from the pulse wave in the individual patient. But we have some strange things, and this is a system for compliance monitoring. It's so-called Spiegelberg's monitor. When you have the intraventricular catheter, and this intraventricular catheter has a balloon on its end. It's 0.3 or 0.7 in volume, and the machine simply expands this balloon and measures the intracranial pressure at the same moment. So we got the reaction. Again, we have the problem that it's good in size, and we use this in size, but usually not in trauma. And this is a patient in trauma, and we put it to the ventricle. We do think that it should be a ventricle, but what we're measuring here is a problem because the ventricles are collapsed. There's a high intracranial pressure, and what we're measuring here may be the compliance of the brain tissue, maybe the CSF. We cannot always be good with this technique in trauma. We're using it usually in hydrocephalic patients. So that's good in science, not in practice. But what else we can measure? What we need to describe the cerebral blood flow is the force that moves the blood in the brain. And this is called a cerebral perfusion pressure. CPP is easy to calculate because it is a difference of mean arterial pressure and ICP. And again, we have a good norm. It was in the end of last century. We know that CPP is changed to keep the CPF at the steady state, and we know the norms is about from 50 to 130 millimeters hydrargyrum. And if we change the cerebral perfusion pressure, it is done to keep the cerebral blood flow steady. And this is called a cerebrovascular autoregulation. Well, the official description of it is cerebrovascular autoregulation is the ability of the brain to maintain constant blood flow by changing perfusion pressure. How it is done? What is the mechanism of autoregulation? We have this same curve here. And if we take the blood as a Newtonian fluid, we can use the Purcell rule that is on the corner of the slide. That the flow, it depends on the pressure, that's CPP. Then it inversely depends on the viscosity of the blood. The hematocrit, for example, on the length of the vessel, well, we cannot change this, and it's very, very responsive to the diameter of the vessel. So the main mechanism is changing the diameter of arterial, yes, and capillaries in the brain. And when we have the non-reacting vessels, they are maximally dilated or it is a maximal constriction, the autoregulation is lost, and we have the linear correlation between the pressure and volume. That means that if the blood pressure is raising up, the intracranial pressure is raising also. For the normal autoregulation, this relationship is inverse. If the blood pressure is raising up, intracranial pressure is going down. Now, the types of autoregulation, of course, there are different mechanisms and different types. It can be static or slow, and dynamic or fast. And, well, what we know about the CO2 regulation, for example, is the autoregulation that we can see in the school children homes when they're falling down. Why they're falling down? Because they're hyperventilating. If they're hyperventilating, the CO2 is getting up. Then we're getting the intracranial hypotension, and the person is bringing his brain down to the heart, to the level of the heart. He's falling down. As for the pressure autoregulation, it's just a simple reaction of a muscle in the wall of the artery. If we're distending the muscle, the normal reaction is constriction. So when the blood pressure raised up, the vessel is constricted and ICP is going down. Metabolic autoregulation is served for the requirements of the metabolism. For example, if we see something strange, our visual center is active, so we have the acidosis going up, some neurotransmitters present, the concentration rising, and we have regional increase in blood flow in that part of the brain. So, I will try to connect all these things I was speaking about. The first thing is intracranial pressure, and when intracranial pressure is rising up, we have the fall down in cerebral perfusion pressure. If the cerebral perfusion pressure is, well, intracranial up, perfusion down, so cerebral blood flow is also down. If the cerebral blood flow is down, there is more blood at one moment in the head. We have the increase in cerebral blood volume, and if the volume is increased, the ICP is getting up. So it is a non-stable cycle, and we have two mechanisms to keep this stable. The first one is cerebral compliance I was speaking about. That is, we are able to compensate some volume intracranially. And the second is a fast reaction to this is cerebral autoregulation. That means we have some chances to change our cerebral perfusion pressure to keep the CBF flow, CBF flow as we need. So what happens in trauma? In trauma, it's easy to disturb the cerebral autoregulation. Nobody knows why, but it is so. So if we have disturbed autoregulation, CBP, yes, it goes down, CBF goes down, there is increase in cerebral blood volume, but this circle stays stable because there is a compliance still in the place and ICP is not rising down. If we have disturbance in cerebral compliance, that's a big problem because autoregulation can't even work if the compliance is disturbed, and we have unstable system, and that is real danger for the patient's life. Okay, that was a theory. Where we are in practice now, well, what is clearly known for everyone here, that if we have what we're looking here, if we have the disturbance in cerebral compliance, and that's a mass effect, that is subdural, epidural, intracerebral, anything, we have to remove this mass effect. That is to reduce to get the compliance better. Well, those who are running the neuro ICU, they know that even we don't have the mass effect, sometimes there are problems with intracranial hypertension, so we have to monitor intracranial pressure to make the MRI to see what is the parenchymal trauma, and that is the level that most of the neuro ICU stops. We are looking to the mass effect, we're taking it off, we're measuring ICP, and if we have the hypertension, intracranial hypertension, we're trying to lower this down. So, what else can be done? So, CBF can be measured, but we cannot monitor it. The same with the cerebral blood volume. It can be measured, but cannot be monitored. What we have is intracranial pressure. We can measure it, and we can monitor it. We can calculate cerebral perfusion pressure. We can also monitor it. We, in general, can calculate the compliance. That is not in clinical practice. And we can look to the autoregulation. We can monitor autoregulation, but usually routinely it's not used. For the ICP monitoring, well, that's not a problem. That's a standard. Every patient who is after the trauma in coma should have the ICP transducer in the brain. We can use the intraventricular drain. Then we have a good ability to drain the CSF and to reduce the volume intracranial, that we win the time to think what's getting this intracranial pressure high. And we can use the intraparenchymal monitor, and it's easy to implant. It's it can be done even not in the hospital, in the helicopter, for example. But we cannot drain the CSF. And the problem with this good electronic stuff, that if we don't believe the reading we're having, we cannot calibrate the intracranial intraparenchymal monitor without taking it off of the head. Okay. What else do we need? A simple thing, just to put these basic things to one place. And that's our standard ICM plus monitoring, that we have intracranial pressure here, we have arterial blood pressure in the same monitor, and we can monitor it. Not only to look at the numbers, but to look at the relationships of these two values, and to calculate cerebral perfusion pressure, PRX, that's pressure reactivity index, and other values I'm going to speak. Now, the easiest way to evaluate the autoregulation is to look to the correlation between intracranial pressure and arterial blood pressure. That is called pressure activity index, PRX. Well, as I mentioned before, if we follow the arterial blood pressure and intracranial pressure, if arterial blood pressure is rising up, the intracranial pressure is falling down. So we have negative PRX, and that's a normal autoregulation. If this PRX is positive, that means malfunctioning autoregulation. And this is dynamics and of the ability of cerebral arterial vessels to change the diameter in response to change in ABP, thus maintaining the stable cerebral blood flow within physiological limits. Marek Czesnika, he's from Cambridge, he described this index, and he was using the transcranial Doppler of one vessel. You can do the same with the intracranial pressure. Well, you can say it's dangerous to change the blood pressure to see if the autoregulation is functioning or not, but we don't need to change the autoregulation, to change the blood pressure, because we have the slow blood pressure waves. Blood pressure is always waning, and we simply follow the reactions of ICP, and we got the autoregulative response. Now, after the description of this index, some studies comes, and one of them coming from 2012, they try to associate, to correlate the outcomes of the brain injury with the PRX index, and they found out that if it is lower than 0.2 or 0.25, these patients survive. Well, actually, in our series is 0.24. Now, if the PRX is less than 0.05, it is associated with favorable outcomes. Well, what happened in the brain? If the ABP is rising up or falling down, it is followed by the ICP. There is no autoregulation. Autoregulation is impaired. So increased ABP is increased ICP, or vice versa. And what is the final result of it? CBF falls down. It falls down because the ICP and ABP is falling down, or if it is increasing, it's intracranial hypertension, herniation, and again, CBF falls down, and we get a picture like this. And you know what does this CT scan mean? It means it's a picture of brain death. As we have hyper dense in the hemispheres, we have some hyper density in the cerebellum. But if you see a picture like this, that's a brain death picture. So that gives us a hypothesis that autoregulation itself, it's bad not to have the autoregulation. But the main problem is the secondary insult. That is the ischemic changes in the brain. So what is really important is the length, the episode, the time in the episode which is out of regulation. That can cause the ischemic damage. If it is on the ischemic damage, we have the worst outcome. So we studied it, we make a study and we publish it, and that's the reason why I'm here. That's the study. So what was the study? All our patients had a severe traumatic brain injury. That means that Glasgow Common Scale was 8 or lower. It was a prospective observational study. It was done in my hospital. We got the ethics committee approval, and we monitor it a lot, but we look to the invasive ICP, ABP, was put to the ICM plus screen. We look to the Glasgow Common Scale, age, gender, CT, surgery, PRX, autoregulation, episodes, total time, and longest episodes, and outcomes which were graded in the Glasgow Outcome Scale on the discharge from the hospital and after 6 months. What is the Glasgow Outcome Scale? Well, that's a good surgical scale. It's not every time used in scientific things because it's very simple, but if it is simple, so everybody can follow it. So we have 1 for death and 5 for good recovery, 2 for persistent vegetative state, and 3 and 4 is disability, but the patient can survive without a help, that's 4, and 3 with a help. So, how we calculated the pressure activity index? So that's a moving linear correlation, coefficient between the blood pressure and intracranial pressure, spontaneous slow waves. And we need some time to measure it, so this period of time was 10 minutes. We were late for 10 minutes for every patient to evaluate his autoregulation. But anyway, it's better than to come in the morning and in the evening to see if this patient is good or bad. And we do not change any treatment for these patients. We simply observe. The results. Well, these were 33 patients, and after 6 months we got a favorable outcome in 16 of them, and non-favorable in 17 of them. 9 of them were dead. Of course, the majority of them were males. The mean age was 36.8 years, and well, these patients who got the favorable results were younger than those who got unfavorable. The average PRX was lower, that's better for those who reached the favorable results, and was higher, that's better for those who were in the unfavorable results. And outcomes, and we divided the PRX to the severity. It's 0.5, 6, 7, 8, and the length of the cerebral autoregulation impairment. And what we got here? Well, that's a good correlation, and that's Glasgow outcome scale. It's on the discharge, and this is on after 6 months, and that's what you probably don't see, but one is less death patients. These are with a good recovery. So the longest period of autoregulation was clearly higher in those who got the worst results. Then we looked on what PRX it is a threshold for those who were dead. So in 6 months, the highest significance was in PRX was above the 0.7, and the duration of this autoregulation discharge was 40 minutes. So that was the threshold, and if we put all these time threshold values to the PRX values in time, we actually got the physics correlation. Yes, its correlation coefficient is close to 1. It's minus 0.90, and is highly significant. So that seems that it makes some reason. And what we make out, we made the multiple regression analysis. And what we found, the very interesting thing, what we thought that it should correlate with the Glasgow coma scale on the presentation. It does not in our study. Why? Well, that was a selected patients. We don't take the GCS3 with white fixed pupils into our study, and we don't the 15 or 14 GCS for in our study. They don't have monitoring. So inside the severely injured patients who had the monitoring, Glasgow coma scale the influence of Glasgow coma scale was not significant. But what was really significant was age, and age is on this side curve. Here is the duration of longest cerebral autoregulation impairment where PRX is above the 7, and the colors are Glasgow outcome scale. Blue, dark blue is Glasgow outcome scale 1, that's that, and the red is good, that's good recovery. So what we can see here, that the younger patients with the less duration of autoregulation get the better results. So conclusion of this study was that the longest episode of lost cerebral autoregulation and age are more significant factors impacting the patient outcomes than the average PRX values. To understand this, I have 2 cases. The first one is the 24-year-old male. He got his injury in a motor vehicle accident. He was a passenger, and he presented with the GCS6, pupils normal. On the CT scan on the left, you can see there are small contusions, and on the MRI you can see that it's typical for diffuse axonal injury. His average PRX was plus 0.18, that is good, and he reached a Glasgow outcome scale 5, that's a good recovery in half a year. And another patient is a younger female, 16 years old. She also got her trauma in a motor vehicle accident as she was hit by a car. Her initial GCS was 4, right pupil dilated. On CT scan we don't see the mass effect, and it's again the diffuse axonal injury. She's younger, her total pressure activity index is even better, it's minus 0.02, but she stayed in vegetative state for half a year. What is the difference? The younger patient, the better total periods. But if we look to the periods of longest cerebral autoregulation loss, that's here, they're much higher. And the difference is significantly higher. So she simply was autoregulating more, but there were longer periods of autoregulation and something happened. This something was ischemic damage to the brain. Okay, so what we got from this study? Is it important? GCS, well, we have the GCS and we can change it. It's prognosis, but not the treatment. Age, okay, we have no influence on the age. Autoregulation, okay, this is just again the observation, but not the treatment. So, was it just a prognostic treatment? No, prognostic study. Well, we all know that it's more easy to disturb the autoregulation. I'm sure we will do it in the evening tonight. But how to make it work again, we don't know how. So, we made another study and we are looking to all these factors, what is interesting. And this is just an interesting slide. We look to the age, to the threshold of age. And this threshold of age is 47 years. So be sure to get your head injury before the age of 47. Because afterwards, your prognosis is much better because of the age. Why it is so? Because the elasticity of the brain and elasticity of the vessel. Okay, the more important slide. The more important slide is here again. It was age on the left. Down it's optimized cerebral perfusion pressure. I'm going to speak this in a moment. And Glasgow outcome scale. And we got this scale, this nice picture, but what is really important here, the best results here. The best results here is for younger patients and optimized CPP, little bit lower than it is the best optimized. What is this optimized CPP? Okay, not that slide. So where we are now, we solved the mass effect, that's compliance. We looked at the intracranial pressure, and what we are trying to play now, where we are playing now, we are playing now here, on cerebral autoregulation. But simply, we can't influence the autoregulation, we don't know how to do this, but we can put a patient in the best situation to keep this autoregulation in a best condition as we can. So, how it is done, the optimized cerebral perfusion pressure is calculated. In all guidelines, cerebral perfusion pressure is set to be more than 70. Not all of them. For example, in Lund protocol, the Swedish protocol, they keep CPP down to 50, but they're playing with the hematoencephalic barrier. Okay, so actually we can calculate the best cerebral perfusion pressure for individual patient. We're looking to the cerebral perfusion pressure when period X, that autoregulation is at the lowest point. We need some time to get this, and usually that's from 3 to 6 hours. So we're late now, 10 minutes for autoregulation and 3 hours for optimized cerebral perfusion pressure, but then we individualize the treatment. And what we get here, if we are down to optimized cerebral perfusion pressure, these are the results of this study we published last year, and these are 42 patients here after severe head injury. If we're a little bit down to the optimized cerebral perfusion pressure, that's 1, that's 5, that's good recovery. The curve looks like this. And if we're a little bit up, that was on that nice picture before, the curve is in the opposite direction. There are more with a good recovery than that. So, again, a nice picture. If we put together cerebral perfusion pressure here, with optimized cerebral perfusion pressure, the best results is from the range from 0 to 10 plus to optimized cerebral perfusion pressure. And that is the reason why I'm talking about, because we can actively influence this. We can change cerebral perfusion pressure by elevating or decreasing the arterial blood pressure. We can influence on intracranial pressure. We simply have to monitor it and to think and to look to this. So I'm coming to the conclusions. that cerebral autoregulation is not just a scientific game. Long periods of impaired autoregulation lead to secondary insult and unfavorable outcomes. We should respect factors that influence clinical outcomes, but we can do nothing. And best available treatment now, at our days, it should be individual to a patient. It should be patient specific. So, thank you for your attention. Are there any questions?